make a difference. Perfect. So what we're going to do is we're going to move on to the panel now. Is that? And I'm only 3 minutes over. So, buddy, that's. All right, we're looking. I think Ken's supposed to be up here. And I believe we're supposed to have Kathy up here.
Aaron, can I ask a question while you're...
Yeah, please ask a question. I might not have an answer.
What the heck is this? So there was something that came out in a literature blast, I think from Russ Trek in the last couple of months, and it talked about giving samples of NRT. The point it was making, I think it was just an editorial, and maybe you read it, that said if somebody had COPD and they were in to see me, I'd more than happily give them Spiriva and say, go give it a try. Yet the current mentality is that we don't give anybody NRT unless they're telling us they're committed. But we've technically understood a diagnosis of nicotine dependence. So why are we so hesitant to give that sample?
Why are we so hesitant? I think some of it, that's a fantastic question.
I'm doing it more willingly.
And honestly, I think it really depends on a lot of different things. One of them is the jurisdiction you're in. One of them has to do with your scope of practice at the profession you work at and not being aware of what you can and can't do. So those are two major challenges because we are scared to get sued. And if we're not a prescriber, it creates challenges. That's why we really do need that relationship with the prescribers.
Okay, I think more the point was that, not that, so let's just say, for example, I'm working in family med clinic and I have the support of a prescribing physician. So it isn't so much that that barrier for me, it's that we're hesitant to actually give it unless somebody's committed to smoke or to quit. If we're talking about smoking cessation and they seem to be, moving one direction, instead of waiting for them to say, I'm ready, why aren't we just offering the sample?
Honestly, it's because of educational bias. We think we know best. Right. Unfortunately, and we're scared. I don't know if anybody else feels this way, but sometimes you're scared because they've got so many things going on. And rather than just ask and say, we've talked a lot about a lot of things. Tobacco cessation is probably the best thing you can do for your health. You've heard it a bunch. Yeah. Can we get started on that now?
Exactly, and anybody who I have offered that since reading that, at least it gives them an opportunity. Well, I'm not standing there staring at them and asking them what they think and them trying to please me with an answer, whether we're trying to pretend they're not. Here, take this home, and if this seems like something that you feel appropriate to go ahead and try, then you have that available. So looks like you have.
Yeah. Anybody else want to respond?
Yeah,
please.
Just add to the, yeah, it's okay. It's
I want to
working.
sit down.
Can I just add to this? So if I understood your question correctly, because I was distracted a little at the beginning, but I think in tobacco, it's still one of the areas of medicine, we'll say, where there's still a lot of judgment on the client because they did it to themselves, like they should just know how to quit. Why don't they quit? And so I wonder how much of it is until the client is ready and committed and they can show me that they can, they're ready to do this, I'm not going to offer the treatment, right? Whereas I don't think in any other area of medicine, and I'll look to the specialists here, we do that. It's like, this is what you absolutely need to do, and I can help you with it. That's just kind of like my reflection. Like, I'm gonna make you work really hard for this.
Which isn't fair. We don't make you work hard for your Spiriva.
No?
Right.
We go get you a big bag of it. Yeah.
Ken, did you have a comment about why samples are tricky? Why it's hard to get people to give samples out as a pharmacist? Yeah, or, her comment about why don't we want to do that?
You're gonna have to speak into that. Sure. I'll use the mic.
That'll help.
Mics are good.
Yeah, I was just gonna ask Ken, as a pharmacist, what do you notice are things that are tricky about trying to give out samples to people?
You want a 1-minute answer or a 4-hour one? I think the issue with samples, and I'm thinking in terms of where I practice. So I work in
Yeah.
diabetes, and people want free insulin, and they want
Yeah.
free monitors, and they want free all kinds of everything. And part of it is an engagement. If the person is engaging in some kind of therapy, monitoring, whatever the heck it is that first, I can't maintain them in the way they need to be maintained with samples. And does it make sense if someone wants to try it to see? Sure, go ahead, but then is that part of a plan? It's just handing them out without some kind of interaction, dialogue, and finding out, is this really even being not just used appropriately, but is it appropriate this time without some kind of interaction and dialogue with the patient? And then how much do you really know them? I don't know. I just, professionally, have I used samples? Sure, but more often not. It depends on where the person's at. I don't know if that answers the question because I'm not.
Yeah. I think that's part of it. It's not the only thing. And also, stuff goes out of date. Do you find that with your stuff you have in your clinics at all, Dr. Selby? Because you hand out.
We don't give out actually samples, because we're in the hospital. There's a policy about samples in the clinic because they expire, nobody's keeping track of them, and you may land up, the inventory. And I think what you're saying, Ken, if you're going to sample, then how does it continue? Where we have, and my colleagues use sampling with short-acting nicotine is sometimes for proof, especially with young people, like they want to give it a try and see during the session whether they get comfortable and it actually works versus it's placebo. Yes, I see that, but it's not here's some samples, go take it home and, handing it out. It's actually as a, key means. That's what we do because I think, with the STOP program, we have great tracking and inventory management because I think it doesn't matter who's giving it out, even if it's an over-the-counter, you need to know the provenance, you need to know what happens, if there's a recall, all those kinds of things, you need to keep batch numbers. So those are best practices of medicine, and I don't think we should just let that disappear if we're going to use samples. So I think have a policy, at least, that you can follow for sampling.
Great. So welcome to our question and answer period that I just jumped into and took over. So you, the audience, have these great experts here in front of you, and we've heard them talk a few times, and of course, questions always get cut off. So what things would you like to know from our specialists up here? Go ahead, Melva.
This is a practical question about working in primary care. Patients on the STOP program so they get their nicotine replacement and or combo oral medications. Some of my patients have mental health issues and they're on mental health meds. So the question is, oftentimes smoking cessation is a journey. It's up and down, and relapse is common. So at what point do you adjust, or does the physician adjust the medication? Like, is it 3 months, 6 months when they're successful, or are they looking for certain side effects, with the clearance of those certain meds, even with caffeine, like you can look at the chart and see all these medications where they're going to go up and down depending. If they're on nicotine replacement, the question is, well, they're still getting nicotine, so, what kind of, I don't have any documentation or anything to allow for how, when the physicians are asking me as to direction, what do you do with that? I don't know. And usually we just talk to the pharmacist, but it's a big question. I don't know who wants to answer it. It's an open.
I'm not touching that one.
Who wants to take that one?
Thank you for that question. I think part of it is to do the ongoing education around this. We've just done a big analysis of all the practice, and we're realizing that we need to do a little bit better education around dose adjustments for people, so the predictors at baseline that can say, this person's going to need a more rapid titration up or in dose increase. And in general, without pointing with all the clinics, we're noticing that the dose adjustments are not happening. So we're trying to figure out why that's the case and whether it needs more direction from our end to say, look, if you've got somebody who's heavily dependent and they continue to smoke, you may, at baseline, these are the predictors. And we're thinking about what we can put into the algorithm and the portal so that you can get an alert that, hey, you know what, this is the baseline assessment is showing this person's going to be less likely to respond to standard dosing. Bring them back sooner, educate them. Here's the pamphlet to help them educate and come back so that you can get to the full dose that they need faster than, telling them to come back once a month or not. And so so it's a combination. We were just talking about this because we just finished those analyses, and we can see this practice pattern come through that people who are heavily dependent, the dose is staying flat. They're giving combination, but they're not bumping it up. So we need to do something. We need to understand whether there's a clinic level issue in terms of policies in the clinic that prevent it, or is it an educational issue? And then what can we do with our technology, that the portal that people use that helps them at baseline identify who's at risk of heavy dependence? So we're looking at, so that's a great question. But I think we need to modify up. And then the second part of your question is, if they've done a complete switch to nicotine, within a few weeks, you should see, if they are on any medication that was induced by the smoke, the polyaromatic hydrocarbon in the smoke, even if they are on nicotine, you should see an improvement. Either they're going to say, my antipsychotics work better, or they're going to start saying, I'm feeling more sedated. And so that generally then requires a dose adjustment. But for the most part, they'll say, my medications work better and I'm not going through anxiety. And the caffeine piece is typically they'll say, at the end of the day, they're getting a little bit more shaky. And so then that requires a little bit of reduction in caffeine intake. So, we've seen it all. So I think we may need to do a little bit more education of the entire community about that. But thanks for that question. And as a pharmacist, if you want to add anything.
Well, I guess what I'd add to that, and conversations about, medications, is which one you use and dosing and all that. I back it up from, the initial dialogue with the person about what's your relationship with smoking in the first place, because that can help guide what it makes sense to do. And critically, because I think a lot of patients and clinicians have this impression, is that some kind of pharmacotherapy is a plan. It's a part of a plan, and it's part of a quit plan. So expanding it out from whatever product you decide upon is what is, and where does this fit in the overall plan of what's going on? And quite honestly, when it comes to like dosing of something, nobody knows the right dose. We have better guesses based on data, but when somebody uses it, we find out how's the dose working, and of course have some kind of part of the plan that's assessing that. Did we get it right, or we got to do something with it? So sure, there's appropriate dosing in that, but it's in a plan that is continually being refined to work better, which could include not just adjust, but maybe change of the medication. Just because you start a medication doesn't mean you're on it forever. And quite often we see that too. Well, I have to go down this path because this is where I started. You can change anytime you like to something that's going to work better if you think it is. So I don't know if that helps add to that answer or not, but.
Go ahead.
I have a question from one of our viewers at home. They work in primary care and I'm wondering how to access these samples that have been talked about.
We can probably put it out on Timed Right, and you can contact Johnson & Johnson or Kenvue. Yeah, and someone's coming. Here we are. It's perfect.
Is this on? Hi, everyone. Adriana Fraser from Kenvue Canada, formerly Johnson & Johnson Canada. I'm the National Sales and Marketing Manager for our self-care businesses. One of them is nicotine replacement therapy. I am happy to announce that we have an extensive sampling program. I encourage all of you to join. If you haven't already scanned our QR code today, Sarah and I are here. Our current sample is 2 21 milligram patches plus the 2 milligram gumma sleeve. We also have trade sizes we're happy to provide you and our demo kits. I am always open to suggestion. We are only as good as the information we have. If you have suggestions on samples, I'm always open to that. We have $5, $10 off coupons. So please, I know we're at the end of the conference, but Sarah and I are still here. Please reach out to us. I sent out 20,000 samples in October alone. So we so we are looking to continue to get them out there. We know they drive conversion. We know they help you. So.
Thank you very much. So we can put that information out on Timed Right.
And certainly when we start talking about the samples, one of the things to note is that with all of the samples that you're using, it's a starting point, and we need to, as educators, really be involved in following up and using it as a way to get our clients back in the door. And I know that sounds really almost flippant, but the fact is, we can throw all sorts of money at all sorts of problems. Samples is one of those situations where if we're not following up, all the evidence shows that counseling is dose dependent. So we need to be doing the two together. So just giving out samples, not ideal.
Yeah.
But with the two in hand, we have a lot more opportunity to really change impact the cessation rates within our regions.
Great. And we have a question over here.
Hi, thank you so much for the panel and all of the advice you're giving everybody. I was actually going to come up here and complain how we are doing a disservice to the young people. 20 to 25-year-olds, they might be in university, they're self-regulating with probably caffeine and nicotine, hopelessly addicted to vaping, and then they have to pay for an NRT that's probably $35, $40, and they can't afford it. And then Johnson & Johnson came up and said that they had these wonderful programs. So thank you very much, because now I don't have to complain about it. But I think I really have to say, the kids that started vaping when vaping first came out, and now they're young adults, and they are completely hopelessly addicted.
Not hopeless.
Oh.
It feels like it.
Yes, very strongly addicted, and they want to quit and they can't, and they don't know what to do, and they're
help.
self-medicating. They might have ADHD, or they're in university, they're very, very busy, they need a stimulant, or they think they need a stimulant, and they feel like there's nobody out there to help them. And I feel like we're not focusing enough on these young people, and I feel like we really need to focus on the vaping and helping them with their quitting methods for sure.
Yeah.
If you want to take a look at our guidelines and the guidance document, I think it'll be great to look at it. When we did the Delphi panels with the international experts, and we wanted to get some consensus as to what to call it. So we went with vaping addiction, vaping dependence, nicotine addiction. Multiple rounds, we were unable to come up
With a name.
with a name and agreement. And here's why. That yes, everybody's looking at this through the lens of tobacco. And if you look at this, is it that people find that they're using more, but they use more and then they stop to a certain level? Do they feel they can't stop? Yes, that's happening. But so they are dependent. The question is, are they coming to harm from it? And so we are really trying to get, we've called it, and there are lots of scales. You'll see we have scales to look for young people, to look at their measures of the behavior. But just to be fair, we are actually just saying, describe the behavior first. Science should never jump onto something because it looks like something else, because that's the risk of making an error. So having said that, what we do need to make it clear is, how do we make the cleanest form of nicotine the cheapest form of nicotine and the most accessible form of nicotine, if in fact people are going to use it? We've been saying this, I think I gave a keynote at one of the tobacco conferences in 2008, where we said, look, it's the smoke that's killing people. If we have to really make sure that if people are using nicotine, for whatever reason, self-medicating, whatever, there's a role for it, and it's got to be the safest form. It can't be something that is not regulated, not manufactured to good, manufacturing practices, doesn't know what you're getting. You can't do that. So just to let you know, there is still uncertainty in the field as to what to call it. And we need to do better studies to actually define it.
Great.
I'm just going to borrow this because I've got a question for Rosa. Because when you get into this discussion about the cost of whatever you're going to use for smoking cessation, is and we've all had that urge. Well, it's as much or less than what it costs for you to buy cigarettes, but we know if you want an interview to go south, that's what you say. So Rosa's going to tell us how to elegantly get around that.
Wow.
That's what we need.
What did he say? What did
That
he
was
want me to do?
cruel. I love that.
People say it's cheap, instead of saying it's
Cheap.
How do you get around to saying, yeah, I'll spend my money on it?
That's when you do an
So he's
analysis.
asking me to solve a huge, a huge problem. It is a real problem though, right? Because what we're selling is not as attractive as what they're getting from the tobacco companies, because it gives them pleasure, it gives them a high, and it's not medication, it's a drug. And so we are competing against that, right? We're asking them, put on this patch, and after, a little bit of time goes by, you're not gonna get a hit, you're gonna, feel a little bit better, maybe if it's the right dose. So what we're selling is not comparing, right, to what tobacco is offering them.
Competing against physiology.
We are, we're competing. And so I would totally stay away from that. I know Peter's gonna totally answer it very differently. That's okay, we're allowed to have but I think the question, I was thinking about this even when, when Aaron was talking, when Peter gave his talk about CBT and the evidence is not great, right? I think what I'm thinking about, and I don't know where the evidence sits on this, so please, this is just my anecdotal observation, is looking more at a values-based approach, right? And rather than compete with something I'm going to lose to, what else is important to that person, and is there something I can offer?
Can I jump in and say long-term values?
Aaron?
Are you kidding? That was an amazing answer. Yeah.
Well, yeah, it was a good answer. But just to add, I think I think to just build on what you're saying, for the most part, most people in this room don't pay for pain. We pay for pleasure.
Yeah.
Just saying. There's some people who pay for pain, but most people pay for pleasure. No hands, we're not taking a poll, no judgment. But so people don't perceive gains, future gains. It's very difficult for most people to perceive future gains. They can perceive losses and issues like that. So, but they have to be developmentally correct, advanced to be able to even appreciate the immediate loss. So it is really hard. And so that's why if we are able to tilt the conversation with respect to price and pragmatics, that there's an immediate gain by switching to the cheapest form of nicotine. If you're going to use nicotine, so you're respecting autonomy, then suddenly the conversation can switch.
Yeah.
Rather than you should spend money on
this.
this, because then they're saying, I'm spending for something that's a loss.
Yeah.
You can't walk into a party with your your arm rolled up looking like the cool kid. It just doesn't work, right?
Great, thank you, Dr. Selby. Brian, did you have a question?
Yes, thank you. So my question goes to anybody on the panel that would care to address it. So nicotine buccal pouches, new on the Canadian market, and they've caused quite a stir. So I'm just wondering what your thoughts are, friend or foe, and why or why not?
Can I just say from a boots on the ground behavioral perspective, it's a nightmare, because I mean, we can look at what's happening in Europe with snus and several of the other pouch systems. It's who it's marketed to that's the concern. We haven't really looked at how it works. It certainly can't consider it a cessation aid at this point. They managed to get it through, and now it's just one more problem that we're going to have to figure out how. You think about how we're trying to figure out how to treat vape addiction right now, based on, and everybody wants an algorithm. How many puffs am I going to give a patch? We're just adding one more challenge with one more delivery device that we have one more way that we're not really sure how to treat them without being client-centered. We're could be in trouble. And this is one of those things, and when we start looking at synthetics and several of the other delivery systems, it's going to be a challenge.
And it's like one more thing for us to learn about, but Ken?
Well, maybe this is.
Just leave the mics on.
Feedback? Wait for it to go green.
Man, you think I wasn't in a rock band at one time? Come on. No, they always turn my microphone off. That's how good I sing. No, but to change the channel a little bit, because, you know, we're talking about options in therapy and stuff, and I find when I'm in my a dialogue with patients around change, and I see my role as a change facilitator, because if somebody comes to see me and nothing changes, they wasted their time, and if they don't need to change, well, they also wasted their time. So my job is to help them find a way to change. And to move over to change, quite frankly, when we see folks, all the easy stuff's been done. So the impression that adding these things makes it easy, we have to be careful with it. It makes it easier, but it does not make it easy. So making sure we don't get caught up in, you know, here's your salvation here beside you in this therapy. This is a very small part of a plan. We're talking about living without your best friend. I always thought it was weird people would call that smoking that, until some patients called it that right in front of me. So it's a piece of the puzzle, but it doesn't complete the job, and the hard work is the other stuff in the plan besides that.
Great.
So I'm going to add, so are people in this room familiar with Zonic?
Yeah.
Yeah, okay, so not very few.
Have people in the audience heard about it? Zonic, you'll see advertisements for it, ZONNIC.
So what it is, it's a very interesting thing, and it's like, talk about unintended consequences of policy. But what it is it's a non-tobacco nicotine product with cellulose that comes in a pouch that you stick under your jaw, and has flavors like any of the NRTs that we have. And it gives 4 milligrams or less per pouch. Here's the difference. One is that it's got nicotine in Canada is regulated under as a natural health product. So there's a whole natural health product regime. And if a new product is coming to the market that is going to deliver less than 21 milligrams by skin, or 4 milligrams or less of nicotine by any other means in the short acting, it doesn't need to go and prove it again that this is going to be a cessation aid. It can ride on the tails of that, and it can get authorization as long as it doesn't meet the definition of a tobacco product, and they can actually say that this is for short or long-term indication for smoking cessation. And when we look at what the natural health products does with this product, is that it says it can be used in adults to quit smoking, for harm reduction, for intermittent quitting. All the indications that you have for other nicotine replacement products in Canada are similarly there for short acting. So what's so wrong with that? Right? It's a new product, people use it, it's now available, there's a marketing strategy in grocery stores and in convenience stores, etc. Here's the rub, is that it is manufactured and made by Nico Ventures, which is an offshoot of a tobacco company. So what people and everybody, you know, from the civil society agencies like Canadian Cancer Society, Heart and Stroke, Lung, etc., and Physicians for Smoke-Free Canada are really worried about is that because these are being sold and marketed as such, as that youth can access them in convenience stores where there won't be an ID check for people to buy it. So even though technically the indication is, you know, 18 above, that young people will just pick it up because the company may be trying to do that. That's the theoretical. We don't know if that's going to happen or not, but that's the concern. Now, technically, you know, nicotine replacement kids can buy it. Now, it is meant for cessation. Will people get dependent on a pouch? Well, we have people who are chronic users of nicotine gum. I've seen them for years, and they do well, and we don't try to take them off. Every time we try to take them off, they get worse, or they go back to cigarettes or something like that. So we find ourselves in this very interesting time where a tobacco company is created a product that, based on the regulatory framework that was to make it easier for Canadians to have access to clean nicotine, Now you've got this actor in the space, which is causing everybody to get a little bit concerned. And to me, I don't know how we're going to address this, because let's say you tightened up those regulations, you'll suddenly tighten up for all nicotine replacement products. So, that's going to be a challenge to walk a fine line. And we already had to, for example, the Natural Health Product Directorate has been doing they were doing consultations during the pandemic about, standards that should be met with natural health products and sampling and all of those kinds of things. But they forgot to ask us, who has the largest mail-out nicotine replacement program, what that would mean for us. And we had to actually get a special letter from the DG, Director General, to say, yeah, no, you're good. This was not meant for you. And I said, well, how about checking before you put out all these things? Because you caused us, So there are issues in this piece that we're going to have to think about. But watch for people who come in with a nicotine pouch and being dependent on it. It is likely to happen depending on how much it gets marketed as a lifestyle kind of product.
Great, thank you.
Great, thank you so much.
Thank you for the question. Was someone else there? Go ahead, Andrea.
Yeah, hi. A couple of us wanted to talk about mental health and smoking cessation, and so we did. But we're not mental health experts. And I think we might have a couple here that have some expertise in that. So what we looked at is things that an educator, an RT, a nurse, a pharmacist, what can we do? But and in our tobacco education book, it talks about having them come back more regularly. But I'm just wondering if there's something you can give us, like little nuggets of truth that we can take home, because a lot of the people that we work with do have mental health issues, and that's one of the reasons that they're using tobacco. And you can choose whichever disorder you want or just speak generally, but I'm just wondering if you could give us something. Thank you.
Thanks, Andrea. The wait for that green light. So, I mean, I think it's a challenge that depending on where you work, right? Because, I'm very fortunate, or we're very fortunate in the area that we work. We've got the time to address this. We can have those difficult conversations, do some exploration, and that's great. And I guess the issue is, how do you have that when you're doing something completely different, but the client has a mental health issue and they're smoking, and what's the connection? I mean, I think education is a first step in helping them understand, right? And it's not simple, and I don't want to oversimplify it, but just helping them make that connection between the anxiety they might be experiencing and smoking. Is it withdrawal? Trying to tease that out a little bit, because the symptoms mimic one another. Their mood is impacted by their smoking. And so again, helping them understand that, while smoking may appear to be helping them, it might be a little bit more complicated than that. And again, I'm not sure where you all work, but it might not be something that you're going to go into depth with, and definitely looking at where can they get that additional support to explore, like, what's underneath all of this. And Andrea and I were having a discussion earlier on about, in tobacco, like in the substance use field, we do talk about the trauma that people have experienced. We talk about what's underlying, driving people towards using substances. And in tobacco, we don't do that across the board. We do in our clinic, but that's very unique, I think, and some others will do that as well. But we know we're talking about the adverse child events, and people who have, what's the score, Peter? 10 or more? 10 or more on the ACE questionnaire are more likely to smoke and have many other complications.
And I'm going to just tell a short story to add a little part to that. A patient I was working with who was heading towards dialysis in a couple of years, just by the trajectory of his EGFR. And his blood sugars were doing pretty good and his blood pressure is pretty good, but he was still smoking, and that was dragging his kidneys down. And so we talked about stopping smoking, and it's a bit of a fluke because of the way things are set up where I live. But he was talking about his struggles. He just can't seem to stop smoking. And so I asked him, I said, what do you like to spend your time doing? And he said, I like fishing. So it just so happens that the dialysis unit at our hospital, if you look out the window, you can see Ramsey Lake, which is the big lake in Sudbury. And I said, there's two ways you can look at this. You're sitting here getting dialysis, watching other people fishing, or you're sitting in your boat fishing, looking at the hospital saying, I'm quit smoking, and that's why I'm out here fishing. Now, one of those is positive and one of those is negative, and we all know negative reinforcement doesn't work because our brain blots it out. So thinking in terms of how we interact with folks, and are we talking about positive things? Because we can come up with negative stuff all day. But where's the positive? And that's where that interaction and dialogue with the patient can become very important to help them find that positive thing that's bringing them, they're heading towards, and where cessation fits in that.
Great.
So if I can just add, one of the things that we've talked about mental health, we've made it really confused, so that people with diagnosed mental illness who need to get that treated. That certainly is not within your scope. That's certainly not what you're going to handle. You're not going to manage symptoms of, psychosis or hallucinations. You're not going to manage people who are, in acute states of depression. The problem with the whole DSM is that usual words that we use, such as depression, anxiety, have been pathologized. So what do we do if it's not your scope, it's not your place? Here's what you can do. And I'll tell you, this really came to me during pandemic, because I'll tell you the patient profile that I saw all the time. And we went virtual, so I was doing virtual. Typically was a woman in her 60s with COPD, living alone, smoking, with her cat. That was the profile that I saw over and over again. No family, no one around, that's it. And so, is that a mental illness, or is the fact that that's a societal issue? And what is different, more and more we're hearing is, I want somebody to see me beyond my diagnosis. So if you do that, you're helping somebody's mental health. So listen, I think it was, listen, empathize. You can do that with anyone, regardless of what their diagnosis is. It's not scope of practice to be empathic, right? Empathize and problem solve, and people just want to have somebody to witness what they're going through without sitting on them and judging them. You do that, people's mental health wellness will improve, even if you don't prescribe a medication, even if you don't do CBT, you don't do anything. That's it. It's really coming more and more. I'm doing this. Those are the things, if we do well, you are going to help people's mental health more than you can think. And I think it makes a big difference. And just as a more okay, so that's the nice, soft stuff and how we should be. Another thing I always ask people is, what is your worst fear about giving up smoking? And then we have to get into the topic about it's breaking up, because it's their only support. That is where you're dealing with that. That's where the anxiety comes. That's where so it's not anxiety about life. It's what that cigarette means to them. And it's really simple. It's about, if you had a friend who's having to get out of a bad relationship, that's what quitting smoking for them is like. Only cigarettes make them feel that way, but they know it's hurting them and they can't get out of it. And they're stuck. So that's what we often have to help people see. And really, it's not scope of practice. It's not some fancy counseling. It's just simple things that we do as clinicians.
Just a little bit of bad news, Peter. I heard a conversation. I don't know if this is actually going to go anywhere. They want to pathologize loneliness now because it's such a huge problem that they want to actually make it a formal diagnosis. Sorry.
So I thank you, Peter, for that response, because I was going to say, one of the things when we start talking mental health and more frequent follow-ups, the guidelines are very clear, that we need to have more contacts with them. If you think about the counseling as a dose dependency, when they looked at that, they looked at the number of hours was most effective to help somebody quit. They were not looking at a patient who suffered from mental health issues. They were looking at a normal patient. And when we look at someone who has mental health issues, more frequent screening, as somebody who maybe isn't doing prescribing, but looking at the PHQ-2, looking at the PHQ-9 on a more frequent basis to identify an early intervention to prevent things from spiraling out of control is so important. And we're boots on the ground. We're seeing the patient. We know the patient. If you're the pharmacist, you're seeing them more than anybody else. If you're the respiratory therapist or the nurse practitioner or the nurse that's working with this, you're seeing them more than the physician is. That's what we need. We need those boots on the ground, those frequent contacts to catch things before they get out of hand, but also to add that human contact to normalize the struggles they're going through, because they already feel abnormal. They already feel like they're not like everybody else. We need to normalize the struggles they're going through and support them.
Great, thanks. Now we have 4 minutes left, so 1 minute each to comment. Oh, a question?
My question was about cytosine. Cytosine? I don't hear too much about it, but I do have some patients who have tried it and very, very successful. And it's a lot cheaper, especially if they don't have a drug plan. And I come to conferences, I don't really see too much of it, so I was just wondering if you could comment.
Sure. So cytosine is a natural product available in Canada. It comes from the laburnum plant. It is actually the inspiration for varenicline, but it's just a shorter acting format. And it's in Canada, it's marketed and sold by Z Farm. There used to be a pharmacist at the head of it, but a guy called Blake Ziegler, but I think he's moved on from there. But you can buy it from the internet. It's a month's worth. It's about $90 now, and gets delivered. But there's very frequent dosing, and you have to, like 5 times a day to 6 times a day, and then you gradually taper off, and it's really a small dose. Achieve Life Sciences in the US is studying it at much higher doses than 3 times a day, and it's only going down a prescription route. So the evidence is pretty good for it. There have been randomized controlled trials, including published in the New England Journal of Medicine, that it's equivalent to NRT. The issue is it's not covered by any plan yet, at least not that I know of, no public plan. People have to put money out. And we've been trying to source it, but it takes a long time for them to deliver. I don't know what's happened. They may have a supply issue, but it's taking a long time to get supply, and not every pharmacist carries it. So it becomes a bit of a challenge. But yeah, it is an option. If everybody says, I want to put natural products into my body, we can say nicotine is a natural product, and we have one more natural product. So then we can give them that.
Great, thank you very much. Now, thank you very much to our panel. This group has lots of questions. And since it's getting on to be late in the afternoon, I'd like to thank them all for coming and giving us their expertise. What? Okay, go for your beef. 1 minute. No, 1 minute and 48 seconds. Go. The microphone.
There's an interesting dichotomy when we talk about cannabis. If you wanted to make your car safer and you invented a thing that when an accident was coming, you'd send a bunch of bubble wrap into your car, they wouldn't let you do that until you proved it was a good idea. And if you came out with a drug that you think it's a good cure for cancer, they said, well, you can't use that until you prove it's a good idea. And you come up with cannabis and you say, well, everybody can use that, and later we'll figure out if it's a good idea.
Yeah.
So are we going to get the same mistake we made with tobacco when the experiment started about 100 years ago, where people were using it to help them deal with stress and problems and like that? And it was great. It was better than the alternative. And we're still going through that study. So just a thought about this strange dichotomy of how we're learning things, but well, we'll see what happens to those poor saps that actually use this stuff in between.
Great. Anything to say?
Oh, we all have to say something? Oh, all right. Sure. I don't have a minute. We've got 30 seconds for now for the rest of us. So anyway, thanks, Ken. Thanks.
You take it, Rosa.
Yeah, I think just to emphasize, I think you've heard it several times over the course of today, is, combination is the more important thing. We don't actually, have the best treatment yet for people who want to quit smoking, but we do have some things that are good enough and that help at least people get started. But they have to know about it, and they have to be offered that support. And yeah, counseling is not fabulous, but it does have a role to play along with the medications. So
Great, thank you.
Great. I feel like we are over time, so I'm going to be really brief. I think it's what Ken and Rosa said. For me, the best issue is that we really need to make sure that people aren't putting things into their lungs that shouldn't belong there overall. Just that's number one.
I think my big issue is we've got a lot of certified educators who are not being remunerated for the work they're doing.
Yeah.
Bottom line is we're doing it off the side of our desk and there's no funding to make true change. If we want to change healthcare, it's through primary and secondary prevention. And honestly, helping people quit smoking, there's no funding. That's my beef.
Yeah. Thank you, everyone, for all your questions, for coming to the conference, and taking advantage of this panel of great minds. Thank you.
Thank you, Kathy.
Oh, watch your head. Oh, almost took her out. She's short. So thank you, everyone. And I have to, first of all, thank all of you for being here. Thank all of this amazing panelists, everyone who facilitated a workshop or spoke here. It's all of you and the volunteers that make this organization really special. I also really, really have to thank the amazing people, because it's certainly not just me that puts this conference together. First of all, Shannon Lenormand, who is our wonderful membership and events coordinator. She keeps me organized, and if you know, like, we all have ADHD, right? But it's like, I've seen the, what women with ADHD look like, and there's a picture of a really messy office, and it's like, okay, so Shannon finds things for me and is super organized and friendly and listens to me when I'm stressed out and cry, and I could not do any of this without her. She is truly spectacular, and we all love her so much. And then, the board members that are here, Kathy Hayward, Aaron Ladd, Cindy Slack, Ken Burns, are retiring, though she thinks she's going to get away. Andrea White Markham, though she's promised she's still going to be involved with all of our programs. We're not going to really let her go because we just couldn't be here without her. And then our spouses, that we put to work. Yes. You'll see Aaron's lovely bride, because they are newlyweds, Sim Ladd. Like, guess she thought she was having a nice weekend away, and we have worked her like crazy for the last 4 days. And Sim, right now, if you haven't got your little raffle ticket, Sim and Shannon will be down there handing some out, so go see her, because we're just going to do those quick little raffle prizes right now. And also they have participation certificates. And my husband, who's probably still out, like, lugging stuff, Paul Gaylor, he is also the one who makes everything we do look beautiful, because he's our art director extraordinaire. And then he comes to the conference, and I work him like a dog as well. And maybe I'm a little cranky sometimes, but they all keep me supplied with Diet Coke, so just to keep me sane. So thank you, everyone. And if someone can bring me the raffle tickets. So we have a little, it's not a lot. We have some of the trauma, Christy Gibson's book there. We have the foundational health education workbook and the tobacco education workbook. We also have Samantha Nutt, who was our keynote speaker at our virtual conference last year, Damned Nations, extremely timely with what's going on in the world right now. And then we also have the fashion statement of the year.
I wore them this
our
week.
CNRC socks. So what we will do is, and Rosa has just kindly donated a copy of Disease Interrupted, with which is Dr. Selby's wonderful book. And what's going to happen if we call your number, Andrea, you're going to help Kathy. You can come up, and it's just first come, first serve to pick your prize. So
Take the socks.
So
And if anyone, did anyone not get a raffle ticket first? Because last call to get your raffle tickets. And yeah, we'll just start. Aaron's going to draw and I'll start reading. 520934. So you're just going to keep coming up and we're going to keep calling. 520903. We've got lots to do. 520854. 520878. There you go.
Yeah.
520911. There we go. 520907. 520927. That's why I like happy people. 520882. I don't know why the socks aren't going, Aaron. Yeah.
I mean, actually, the good grab of that tobacco handbook,
Yeah.
that's a good grab,
Yeah.
especially if you don't already have it.
Yeah. 520924.
Aren't they all 520s?
Yeah, okay, but 520909. There we go.
Take the socks.
520879. 520908. 520928.
One up. We're going to go one more.
Did I go too fast? There we go. 520929. Okay, yay. 520860. There we go.
Cindy.
520913. 520866.
Jamil wants
Yeah.
socks.
Tell Jamil I'll send him some socks. Yeah. Okay. 520942. They're making up their mind. We're going to keep asking. Okay, we're going to, okay. 520863. The Foundational Health Education Workbook is $110 value, so just saying. So we got 520863. Okay. Okay, one trauma book left and some socks. 520858. 520916. How did Cindy get two?
How did you get two?
Wait. No, you can't have two. No. Yeah, sorry, had to be here. That was the rules. Sorry, Cindy. Yeah. 520877. People have, there we go.
We got one book and 4 pairs of socks left. 520876. Okay, we have 4 pairs of socks left. 520939. Oh, yeah! He wanted the socks.
He just wanted the socks.
It was meant to be 520920. The hottest fashion item around, the CNRC socks. 520906. Is that it? One more. And here it is, the final pair of socks. 520912. Do we have the 1-2? 1-2 going once.
Oh, no.
Oh, do we find 1-2? Yay! Okay. Awesome. And let's all celebrate, everyone. Thank you so much. Because we're back. Yeah. Yeah, go ahead.
So as chairperson of the conference committee, I want to extend gratitude for each of you for coming. I also want to once again and say thank you to Cheryl for all she's done. She truly does make this happen, and I can't tell you how she just makes it work. Even when it looks like things are going to fall apart, she makes it work.
Look like that. Come on.
That's not what those phone calls. But thank you for coming, and we'll see you in 2 years. Hey, do we have a location yet?
No, we do not have a location yet. Send me your suggestions.
Brandon, Manitoba in January. Oh, and can you turn this back on for a sec? I do have some samples here if somebody needs a couple samples. I can't take them.